Welcome to Part 2, Pelvic Disorders. We're going to describe the various disorders and the treatment protocols. We begin with uterine prolapse. So what happens here is there is decrease in the support structures of the ligaments to keep that uterus up in place. And so the uterus starts falling into the vagina, and it may eventually completely prolapse out of the vaginal introitus. So this woman is going to feel pelvic pressure and heaviness. Her male partner may notice that he's banging into something that was not there in the past. The cystocele. The bladder is prolapsing into the vaginal vault. So this is affecting the anterior vaginal wall. And so when you go to do a catheterization on someone who has this disorder, and you move the sheets, you have her in the frog leg position, and you look down and you're looking at something that is actually protruding out of the vagina, and it's shiny and pink, and you're looking at it like, what the heck is that? Well, that's the bladder. Now the urethra is still up there, but you have to negotiate around that cystocele. So just spread the labia, use that hook position with your second and third finger to lift up, and you will see that the urethra is above that cystocele. So these women will have urinary retention, and they also may have urinary dribbling because this bladder fills and they can't completely empty, and then when they cough and sneeze, they may dribble urine. So a cystocele, a rectocele, uterine prolapse, none of this stuff happens immediately. It's progression over time. So next is the rectocele, and as I said in part 1, constant straining with stool promotes development of the rectocele. So what there is weakness of the muscle support between the posterior vaginal wall and the anterior rectal wall. And so the rectum is going to push toward the vaginal space because it goes to the point of least resistance. Then we have our enterocele. Now this one is going to present with more pelvic pain because when you see where the weakness is, it's at the upper aspect of the vaginal wall. So it's between the rectum and the uterus. And what ends up happening is when she's straining or coughing or lifting, a loop of bowel actually goes between that space of the rectum and the uterus, and we may have just this funny looking structure that's protruding into the vagina, and it isn't the cervix, it's not the bladder, and so this is going to need surgical intervention if the woman is healthy. So let's talk about the non-surgical treatment. So you may or may not have heard of a pessary. Men like to talk about pessaries. You know, their grandpa had a pessary because he had a hernia. Well, that's an external device that will hold a hernia in place. The pessaries we're talking about for pelvic support are internal. And you can see the variety on the bottom. We actually are inserting these into the vagina. And we have to teach our patients how to get them in. So it's similar to putting in a diaphragm where they have to not have any qualm about touching themselves because they're going to put this in and they're going to take it out to clean it. They do stay in there. They don't have to take it out on a routine basis, like definitely not every day. But one of the things that we have to consider is what is the state of the vagina itself, because a woman who's gone through menopause and did not use any type of estrogen therapy, they get what we call atrophic vaginitis, and so the vagina is no longer rugated with all those wrinkles. It's very smooth. When we try to put a pessary in that tissue is going to start cracking and bleeding and having an erosion. And so what we'll do with that is send the patient home with topical estrogen therapy, either Premarin cream or estrase cream. They fill up an applicator, and the doctor will say it's either a gram or 2 grams, and they'll do that for a couple of weeks, twice a week, so that what we're doing is priming the vaginal tissue, getting it to respond so that it has more pliability. And then we can put in the pessary. So there's a couple of different types. When you look at on the bottom right, that U, that's a ring. It's a very hard ring. It's hard to even get them to bend, but the lady has to bend it in half and then insert it. And the beauty of these is similar to a diaphragm. It seeks where it's supposed to go. And so she has to get it started and push it up in there, and then it's going to go where it needs to go. Then she inserts her fingers a little bit more and makes the adjustment so that it's either pushing that bladder forward and up, or it's holding the uterus up. So this is used for cystocele and uterine prolapses. For the women who have a rectocele, we want them on stool softeners and fiber to avoid the straining. We want to instruct our patients to void on command. You need to go pee every 2 to 3 hours to avoid having a very large bladder, and then the cystocele protrudes more into the vagina. Now, because I said that this is a slow process, when we notice that there's starting to be a rectocele, starting to be a cystocele, or a little bit of uterine prolapse, we can actually teach the woman to do Kegel exercises so that she can develop the musculature and hold all of these structures in place. Now, one more thing before I go on to discuss the Kegels is I want to bring your attention to the top right slide, which is the inflatable pessary. What the woman does is inserts the pessary up into the vagina where it needs to go, and you can see where it is going up right against the cervix, and then using the bulb, similar to what we use to inflate a blood pressure cuff, she will pump it several times, and then that donut that's in there will inflate with air, and it will provide the structural support that's needed. And then she can take that bulb off, and it will it has a little lock on it. So yes, there is the tube that's going to be right at the introitus, but it's not too long, and she shouldn't be able to feel that when she sits down. So let's move on to Kegel exercises. What we're doing is teaching the woman to squeeze the muscles of the pelvis. So what I like to have them do is squeeze the muscles enough to stop the flow of urination, and this is a good time for them to do it. We have all kinds of ways that we've taught women. Put the red dots. Whenever you see a red dot on your refrigerator, do 10 Kegels. Oh, you like to have ice cream. Every time you reach into the freezer and you're going to get ice cream, do your Kegels. But that really isn't realistic. What do we do every single day? We pass urine. And so we hook it with that urination because it's twofold. It reminds them to do it, number one. And number two, they can actually see that what they're doing is working. Because initially, they're going to try and hold that urine, and stomach's going to leak out. But the more and more that they do these exercises, when they really have to go and they sit down and they let the urine flow, and you tell them, now stop it, hold, 2, 3, 4, 5, let more go. Initially, they can't hold it at all. But all of a sudden, man, I'm not only holding it for 5 seconds, but I can hold it for 10. So we have them start, stop that urine flow, and eventually there's a lot better pelvic support. So you want to have them hold for 10 seconds and then release. So if they can do it 50 contractions a day for 4 to 6 weeks, we're doing great, and she'll notice the difference. And so I put a little picture of Oliver Gandolf the Gray, the one who you heard in previous lectures. There he is, our boy. So if estrogen therapy doesn't help, if Kegels don't help, if the patient has used pessaries or is unwilling to use a pessary, then they're going to resort to a surgical treatment. And so what they can do, the most conservative is doing the pelvic sling. And so they're literally just moving muscles around and lifting the bladder up and suspending that uterus a little bit better. If they do a hysterectomy, they may do the supracervical approach because keeping that cervix in is going to help to support the whole pelvis. Or they can do the standard hysterectomy where they take the uterus and the cervix. So this ends part 2 of pelvic disorders.